Test, test, test. Okay, we're going to get started. I'm going to start it as Vice Chair of the Finance Committee for the Cook County Health Board of Directors, and I'm always willing to serve in this way because I get the gavel. So with that, I'm going to call this meeting to order, and I'm going to ask the Secretary to read the roll.
Director Green,
Present.
Director Harrington,
Present.
Acting Chair Lowry,
Present.
Director Robinson,
Present.
and also for the record, those directors also attending: Director Masuda Barnett, present, Board Chair Garza,
Present.
and we have Director Sorrell remotely.
So I will entertain a motion
Present.
to allow remote participation?
So moved. Second.
All in favor say aye.
Aye.
Aye. Thank you. The ayes have it. Any public testimony?
We did not receive any, registrations, no.
So with that, we will receive an overview of our budget presentation. Pam Casera will provide the overview. Pam.
Oh, and for the record, we have Commissioner Tara Stamps. Good morning. Good morning.
I would like you, if you would, Commissioner, to just share with us your district and some of your initiatives, and certainly any that are touching on healthcare.
My name is Tara Stamps, Cook County Commissioner of the First District, which is basically from west to east, is from Manheim to Western, and north to south is Branson. Our care center is in town. But that's the rough cut of it. I was becoming a Cook County Commissioner. I was a elementary school teacher for 6 years. I am still a administrator of the Chicago Teachers Union. Union work is really dear to my heart, but young people remain a central focus of mine. And the way that found itself into my elective role is my chief and abiding concern, what I'm calling, as the others are, a mental health crisis, particularly among young people, even more specifically among young Black men who have the highest going suicide rate of any other group.
And then there's that. Forgive me, I hope you guys caught the rest of that, but, and so to that point, I started an initiative called Shop Talk, Sharing Hope and Overcoming Pressure, where I've partnered with beauty shops and barber shops, throughout the First District, and now we've had the pleasure of actually going to the south side and have been invited to the south suburbs, and we'll be making a second appearance at Central State University, where I've partnered with my son, who facilitates Shop Talk specifically for the athletes at homecoming. But what Shop Talk does is leverages the historic kind of safety of the barbershop and beauty shop experience and just kind of pivots that conversation to mental health with a very specific focus for each Shop Talk experience, where the young people leave not only with a life skill that they can use in real time, but also mental health support, resources for housing, insecurity, food, jobs, any of the things that our young people have said is important to them. We try to make sure that whatever community we're in, we're grabbing those resources and making sure that they're available to the young people. And I've partnered with Collaborative Bridges, which is also in my district. Donald Dew usually participates and sits in so that there's a mental health professional at each of the sessions. We've had others as well, but going forward, I'd like to kind of get a more committed one, and Donald Dew has been the most committed mental health professional to be involved. Last summer when I started Shop Talk, we did 8 sessions of just barbershops. From January 2025, we've gone to barbershops and beauty shops, so we've had 16 sessions this year. And a couple of kind of like one-off, as a matter of fact, last week, we were at the Chicago Teachers Union block party for teens, and we wrapped up. Larry's Barber College sent over 5 barbers, and we did mental health games. We kind of changed the conversation so there'd be more interactive. Following that, recently, I passed a resolution making footwork, which is really a street dance that has a culture on its own, but what's important about it is that it's unique to Chicago, and it really has captured the minds and the imaginations and the time and creativity of young people, Black and brown, throughout this county. And they were asking, because they do so many events throughout the month of August, they were really wanting to be recognized. And so I took the lead on that. And the wonderful thing about that is not only was there an opportunity for these young people and not so young people, some of the originators of this art form, to be recognized, but there is definitely a connection between artistic expression and mental health. And so I'm always looking for where is the mental health component in anything that I take on, and how does it help young people. So that's the work that I've been doing almost exclusively. And of course, there's some other OPEB projects in the work, but not necessarily health related. So I'll just leave it right there.
Commissioner, thank you for your great work.
Thank
and
you.
For joining us today. And, you know, collaboration is something that we in this room and beyond embrace. And I am facilitating a meeting with Commissioner Stamps and Dr. Kim, one of our directors, because as you may know, Dr. Kim has her own barbershop initiative. She's been collecting hair samples and then using that to determine the cortisol levels of individuals. And, you know, we know that stress, which is shown through your cortisol level, is a clear component of mental health. So when I heard that, and I know the work that Commissioner Stamps is doing, I said, let's get you two together. So we'll be scheduling that in the coming weeks. So again, thank you for your good work. Appreciate that. Budget presentation, Pam Casera, floor is yours.
Thank you, Vice Chair. So this is the introduction of the FY26 proposed budget. I'm going to turn it over to Dr. Makaitis for opening remarks in a second. But just to preface, usually Chair Ryder would preface this by saying this is the introduction. So sit back, digest, absorb, and you'll have many, many more times to hear this, starting next week with public hearings, coming back to our Finance Committee, and then again our board this month. Your briefings this month, we'll be sending out this deck along with a lot of supporting documentation next week after the briefings, both the director and commissioner briefings. So again, this is just the introduction. Absorb and digest, consider your questions, and we'll come back to answer the bulk of those at future meetings. Dr. Makaitis?
Thanks, ma'am. Well, good morning, everybody.
Good morning.
Good morning. Today, we're presenting the board with Cook County Health's proposed fiscal year 2026 budget. To say that the upcoming year presented a budgeting challenge is an understatement. As you know, we're already feeling the impacts of reduced reimbursements related to the sunsetting of health coverage programs for immigrant adults. Looming large are the planned federal cuts to Medicaid and other social service programs that are expected to take effect in 2027. This budget demonstrates our efforts to prepare ourselves for upholding our mission in a time with fewer resources and greater need. Our budget planning was centered not just on our bottom line, but on preserving and reinforcing the key services on which our patients, members, and communities rely. During this fiscal year, the team rallied together to identify cost savings opportunities, meeting our goal to reduce expenses by 10%, including a temporary hiring freeze for select positions. These efforts, although difficult, will carry over into 2026. At the same time, we also made important progress in reducing our agency utilization. Cook County Health is committed to our labor workforce and collaborating with our union partners. We've reduced agency FTE positions by more than 400 since last fall, and now are under 1,000 agency workers, further reducing costs. More than 230 agency staff members have accepted offers of employment with the health system. While our work is far from over, we will continue to build this positive momentum. As we step into the coming year, we are prepared to meet the challenges that 2026 will inevitably bring, and are prepared to reinforce our foundation for the even larger storms on the horizon. Despite these threats, we are not without hope. This hope is grounded in the work our team is doing to transform Cook County Health into a more nimble and modern organization. We're approaching our work with both vision and urgency. We see an opportunity to build a more equitable, more efficient, and more compassionate health system, not just for today, but for generations to come. In the coming year, we'll continue enhancing care quality and improving patient and member satisfaction, while building on recent progress in employee recruitment and retention. We are also preparing for continued sustainable growth in public health and sponsored programs. We're embracing technology to modernize care delivery, strengthening our revenue cycle operations to ensure financial sustainability, and entering into more value-based and risk-based agreements to drive both quality and revenue. There is no doubt Cook County Health's work as a provider of care, a steward of public health, and a health plan will only be more essential in the coming years. As I continue to say, we will do as much as we can for as long as we can. We are pushing ahead with the unwavering commitment that has always defined Cook County Health to protect the health, dignity, and well-being of every person who walks through our doors, regardless of their ability to pay or immigration status. Before I turn it back to Pam, I'd like to extend my gratitude to this board for your leadership and guidance, and to President Preckwinkle and the county board for their support. I'd also like to thank Chief Financial Officer Pam Casera, Associate Chief Financial Officer Scott Spencer, Budget Director Joe Francois, and the entire Finance Department for preparing this budget in a time of great uncertainty. Of course, this work would not be possible without our entire Cook County Health team and their exceptional contributions to the health system on behalf of the patients, members, and residents that we serve. Thank you again, and I'm going to hand it back to Pam.
Thank you, Dr. Makaitis. And once again, Pam Casera, Chief Financial Officer for CCH. I'm joined by my colleagues to my left, Associate Chief Financial Officer Scott Spencer and Budget Director Joe Francois. Debbie will pull up the presentation. Going first to the agenda, we'll be looking, of course, at this year's accomplishments we always start out with, and then on to next year's initiatives. We'll look at our historical trends for our newer board members. Then we'll present the 2026 proposed budget. We'll touch on our special purpose funds, and we have some supporting documentation, as we mentioned, will be sent out next week after budget briefing. Next slide, Debbie. So I don't want to downplay all the good work being done at CCH. These slides are shared periodically with the group. There's a lot of accreditations and awards and recognitions listed here. The ones that especially impact the budget are related to expansion, growth, optimization, efficiency efforts. So to call out a few, and these either impact either our revenues or our expenses. On the left side, converting close to 200 agency positions to fill vacancies. We opened our new Bronzeville Health Center. We opened the CTSU, the Clinical Triage and Stabilization Center at Providence. We opened dental services at North Riverside. We executed an agreement with Loyola to expand County Care Network, adding 700 new providers. On the right side, we launched the birthday health screenings to promote streamlined access to low, no-cost mammograms and prostate cancer screenings. Thank you, Commissioner Lowry. Added a new primary care slot utilization metric to value-based care measures, improved IT service ticket management, and increased the number of county care members filling their prescriptions with CCH Pharmacy. Next slide. Looking ahead to next year, again, there's numerous efforts related to improving quality scores, patient and employee satisfaction, and achieving various awards. The ones to call out here that affect, again, the revenue or the expense budget numbers are highlighted here. Starting again on the left, making progress in reducing the vacancy rate and reducing agency utilization, continuing successful retention programs to maintain low turnover, implementing performance and process improvement initiatives throughout the organization, hiring, procurement, surgical optimization, throughput improvements, et cetera. And then on the right, entering into additional value-based care contracts to drive higher quality outcomes and yield positive financial impact, and improving and maintaining a positive operating margin through denial reduction, increased claim submission, no closures, and improved billing technology. Next slide. So first, we'll take a quick look at our historical trends. This slide shows the budgeted FTE fluctuations and trend over the last decade. You can see that we're budgeting a 110 FTE increase over last year, which is primarily related to bringing previously ARPA-funded positions onto the health fund. We'll talk about that more as we look through the budget presentation. Next slide. This is a busy slide, but this slide shows our volume trends over the last several years. You can see some areas have shown slow but steady growth, in areas we've put concentrated and strategic initiatives in place, while others have remained pretty flat or have even been declining. Next slide. Sure. I'm sorry, Cook County?
The Cook County members and emergency visits.
Yeah.
Can you explain that slide over here?
Sure. Just the dark blue shows the graph of the Cook County membership over time. So we hit the peak in 2022 and has been slowly decreasing throughout the last few years during redetermination. And then the red line just shows the ever so slight upward trend. Actually, the last couple of years, pretty flat emergency room visits.
So that emergency room, is that specifically?
No, no, just two separate statistics.
Okay.
Yep,
That's
yep,
all.
yep.
No, thank you.
Yep. Okay, next slide. All right, we've shared this slide a couple of times now as well, but we wanted to touch again on the federal and state funding cuts we're facing and preliminary estimates on the impact to CCH. You know, as of the time of the budget, the only known impact was the state sunsetting of the health benefits for immigrant adults program, which is $111 million annually to CCH. That has been budgeted. Yet to come is potential dish cuts if no congressional action is taken, which could potentially be another $100 million impact to us next year. That impact has not been budgeted at this point. However, over the next few months, we hope to know more and a definitive answer be done, and then that could potentially be incorporated through the amendment process. And then in the out years, we still have some more coming, not affecting us in this coming budget year, but in the following budget year, related to work requirements and redetermination happening every 6 months rather than the annual process that it is now. And of course, as these compounding effects, we're going to see more uninsured patients, more demand for care at CCH, and our charity care is going to go up.
Yeah, I know these
Director?
are estimates. Are these
Yes,
low estimates, high estimates, or middle estimates?
I would say they're middle of the range estimates.
So they could be worse.
Could be worse, could be better, yes. And then the other side of that, of course, is that other social service programs are being negatively impacted in the community and cut, and access to care from other safety nets are being reduced or closed as well.
One more question.
Sure.
On the federal budget bill, when we look at the 10% of individuals lose Medicaid coverage, and between 5 to 12% individuals lose coverage may be eligible for re-enrollment, when we look at those two percentages, we combine it together approximately 22% somewhere up to
Yeah.
22
So-
to 15%.
When this first came out with, right, there was estimates up to almost 40 to 50% of all Medicaid patients could lose their coverage. So this compounding 10% here, 20% there, 10%, so yeah.
Okay, so my question is, when we look at those numbers, does that take into consideration any type of efforts that we may employ to try to reduce the number of people that are impacted? So does that number include our efforts?
No, it does not.
Okay.
These are just raw estimates at the top, right off the top. Yes.
Pam, excuse me, Pam.
Go ahead, Chair.
Thank you, sir. Want to understand the percentages. The 10% of individuals that lose Medicaid coverage, that's your estimate. Those individuals are probably not currently working.
So
Requirements.
in Illinois, we believe that those who can work are working, but we still,
I
yeah,
agree.
yeah.
And
But-
we used Arkansas as an example.
Yeah.
They tried to implement back in
Right.
2018. They had I think 18,000 people lose coverage. When they look back, 97% should have maintained on the rolls. And it was but for doing paperwork the right way, having the right address to contact them. So it was all out of, red tape that basically got them taken off the rolls. So we're not thinking that 10% are not working. We're extrapolating from that experience and saying, well, this could be the impact that we see here. So to your point,
Got it.
Correct.
Director Robinson, doing all that upfront work, right, collaborating with the MCOs, making sure that we're doing everything we can to maintain coverage. That's a conversation that we're actually pulling together in the coming months. So,
Got it. And just to make sure, these two numbers that we're looking at, these two groups, they are exclusive of each other.
Correct.
So there is no overlap.
There
That
could be
would
some
be-
overlap, but
Okay.
we've estimated,
Okay.
made the estimates separately. Correct.
But you're recognizing the 5 to 12% as, I guess, slippage?
Yes.
Just delays and people
Yes.
getting redetermined and
Right.
paperwork and that sort of thing.
Right.
And
They would
how it
fall off the
travels
rolls.
with the federal government.
If they came in to seek care, we would help them re-enroll, but if they just avoid seeking care, then,
Right.
yeah.
I think that's
Yeah.
fair.
Yep. Any other questions on this side?
Yeah, I have two.
Sure.
Quick ones. So in the context of the elimination of resources for those who were HBIA, we had talked previously about that affecting 17,000 or so members of county care. With the 8,000 CCH patients noted here under the state coverage, would that number be included in that 17,000?
It would.
Okay, good. I just want clarity on that. And then relative to now the Medicaid work requirements, do we already have boarded or are we planning to have some type of work-related offering or opportunity for individuals who would be affected by this change? Maybe a collaboration with Chicago Cook Workforce or something like that?
So we're in the process of pulling together a broad group in the healthcare space on the heels of the meeting that President Preckwinkle pulled together
Good.
about 2-3 weeks ago. She had various sectors in the room, including business, philanthropy, healthcare, education. She had a very broad kind of stroke of discussion. And follow on to that, we're now talking about doing that as in the healthcare space. So MCOs, the state, providers, philanthropies, again, the advocacy groups, getting them all together in a room to really talk through how do we cross-pollinate and ensure that we're doing everything and sharing ideas and ensuring that we minimize the impact as much as we can.
No, obviously, I'm here to help. Let me thank you. Thank you.
I'm sorry, let me go back to the 5-12%, because our good chairman here made a question about, that's not necessarily that they're losing all of it, but it's gonna be a slippage or reduction. So then, and that's approximately 50 million. So my question is, can we use predictive modeling to figure out who those individuals are, and so we can actually contact them earlier to reduce the amount of the loss that we would actually see and their coverage and health?
Yes, I would say yes. I mean, there is outreach going on now and would continue to, I mean, as we've gone through redetermination in the past, right, we've set up redetermination blitzes, I guess we'll call them, to be able to get people signed up. And we're talking about staffing up additional financial counselors to help, but so we can get it done on our side. The patient comes in and we redo the applications, but unless the state also adds resources, they could, which again, delays coverage, right? Delays payments for sure. And so it'll become a administrative nightmare down the road. But again, for this coming budget year, it will not impact us.
Yeah. So Director Robinson, to your question, the answer is yes. We are looking at more robust data analytics, possibly AI. How do we flag earlier and ensure that we're engaging better with the people who are kind of on the brink of coming up for redetermination? And that's part of that conversation that I was alluding to, of pulling everybody together and how we leverage those resources as a broader community.
Go ahead, Joe.
Yeah, I just want to bring our attention to the compounding effects because they're below the numbers, and I think they're dramatic. Uninsured patients up, demand for care at Cook County Health up, charity care costs up, down, cuts to other social service programs negatively impact community health, which is big, as well as access to care as other safety nets reduce services. So this is a ticking time bomb. So we need to look at the numbers, but we need to work with our colleagues within Cook County and out external Cook County to see what we can do to mitigate those compounding effects.
And I think my comments follow suit to your point, Joe, and Vice Chair Lowry's comments about the opportunities within county to cross-pollinate, or I'm just going to call it integration. I sat in this board 4 years ago proposing that or pulling for it, and I just didn't see it acted on, and I know you're committed to it, but this is the opportunity to cross-integrate between county care, ambulatory services, specialty care, the hospital care, and then going beyond that into other programs that the county provides support to community members with. I mean, somehow we've got to figure out how to integrate that, even if it, well, I'll just leave it at that. But I think that's just the thing we have to do. And when I saw the engagement level of how many county care patients are engaged in, I think it was like 10% in the Cook County Health ambulatory clinics. I mean, I got to assume that's not with any effort. So imagine if we're more intentional about it, what that would look like. And I say that because I believe in the county's high quality service delivery model. And I've said it, county, if we're good enough to provide care in county care for patients, I think we're good enough to provide their service care in the clinics and in specialty care and in the hospitals. So it's just a statement, but I think it fits in with the last part of this conversation.
Thank you, directors. All of that discussion is perfect segue into the next slide, continuing the doom and gloom prophecy. Here you can see that we've enjoyed favorable surpluses the last few years with revenues exceeding expenses, but that is projected to change in the out years as salary increases, supply cost inflation, and pending additional Medicaid cuts come into effect, creating a deficit for the health system. And some of you have been around. This slide used to go further back, I would say, into 2018-19, when the health system did have significant deficits, and we'll be projecting to do that again in the future. Next slide. Okay, now I'm going to turn it over to Scott Spencer to go through the actual proposed FY26 budget. Scott?
Thank you, ma'am. So, Scott Spencer, Associate CFO for CCH. Walk you through, starting with the assumptions and kind of what the overall strategy is around the budget as we prepare it. So the first couple of things we need to do is what our assumptions are going into the budget, and also determining our values. We have to determine the volume so we understand what kind of revenue expectations we have, because we need to know what expenses we can support. And as you all know, we need to submit a balanced budget as well. So we start there on the next slide here. So some of our major...
Sorry, excuse me, Scott. I believe Director Green has a question.
I did, but it was regarding the last slide. So just to keep the organization and flow going, I'll hold it to the very end if that's okay. How do you prefer? Commissioner, Director Lowry, is that okay?
Yeah,
Okay.
that's fine. Thank you, Director.
Debbie, can you go back one?
Yeah, so here we got our budget assumptions for the year. So again, our major drivers here. So we start by looking at what the run rates are for the current fiscal year as our baseline, and from there adjust up or down depending on where we expect to land. Director Harrington.
What does the acronym PMPM, capitation rate, stand for?
That would be per member per month. That's associated with the health plan.
Member per month?
Per member per month, yes.
Per member per month.
Yes. Yep. Monthly rate, effectively. So we start at the top here. We have the 10% expense reduction. So there is a carryover. So if you think back to the expense reductions that were put in or are being put in place to close the gap on fiscal 25, much of that will carry over to fiscal 26 and is included in our budget. In addition, we have additional GI, gastroenterology volumes at Provident, as well as additional observation days in the crisis stabilization unit. We have a 4% charge master increase to market rates, and what that is the revenue cycle team looks at our current charges and where our charges are below market. We increase those rates, so we're not leaving any money on the table. We also added Medicare and Medicaid rate increases, as well as additional revenue anticipated, again, going back to that per member per month for the capitation that we just spoke about. And then subtracting from the bottom line is going to be, which is natural salary progressions or rate increases that we expect to see in regards to salaries. And then, of course, the county care membership, we're expecting to decrease to about 362,000. So next slide, please.
That's a big decrease. We're now approximately
It's about a 8% decrease in membership. But as you'll see, we have when we get into the revenue here, we've got about a 14% increase in the capitation revenue. So as we look at, and that'll become more clear in the next couple of slides. We've got a revenue slide and an expense waterfall that does a nice job of kind of laying things out. But once we have our assumptions set, now we turn to setting the volumes. And so as we look at what our volume assumptions are here, starting at the top here, we do expect surgical cases to increase compared to the fiscal 25 budget, and that's due to some additional GI volumes at Provident. ER visits are lower than our FY25 budget because we won't have the volumes associated with the new arrivals. However, we're budgeting flat, FY26 flat to FY25, as we might see some increase in ER visits. Yeah, as patients that have lost coverage might seek care through the ER. It's difficult to know the timing there. It may be 1 year, 2 years down the road, but we feel comfortable with that number. So as we work down the slide here again, by and large, volumes are expected to be mostly flat. Average daily census at Stroger is coming down a bit, budgeted 317. We're projecting 326, but budgeting 306. But there's been some improvements in the length of stay that is impacting that number. And again, the last line there, county care members being budgeted at 362,000. So next slide, as we look at the revenues now. So starting at the top, we got our NPSR, or net patient service
So
revenue.
Scott, just a second. So the proposed budget for FY26 is $5.144 billion. And the breakdown of that, Scott will go through.
So net patient service revenue, we're budgeting 581, which is $264 million lower than our FY25 budget, due to the Medicaid impacts that we just went through. Governmental support overall increasing due to directed payments being under budgeted in FY25. We have VIPA and GME all budgeted flat for fiscal 26. And as Pam mentioned, we aren't budgeting any dish cuts, but we're obviously eagerly awaiting what Congress is going to do in the fall in regards to delaying the dish cuts, which they've done the last 10 years. Health plan services, so county care membership decreasing, but we do have rate increases. So it was about a 14% increase in the rate and about an 8% decrease in the membership. The next line is the tax allocation, so a small increase there, $10 million, small but important. And that is due to the county agreeing to increase our tax allocation to cover, mostly to cover the ARPA positions that are coming over to the health system. And then last but not least, the other revenue, we've got the retail pharmacy expecting to see similar impacts from federal and state policy changes to Medicaid. So a small decrease there. Next slide, please. I'm sorry, Scott. I would like to understand. Yeah. If you can help me out with the two big drops that we see in the revenue, net patient revenues and with the health plan, that's where everything's falling out. Can you help me out? Help me understand what's happening here. So I'm not questioning, I just truly don't understand. Yeah, so those are the decreases that are driven by the additional charity care that we've seen, and the payer mix shifting from Medicaid to private payers, so self-pay in many of those cases. We also have seen some volume shortfalls throughout the year, and so budgeting, path forward is that those volumes are going to hold pretty steady. Okay. I think I understand the net revenues going down. The health plan is going down significantly from the previous years. That one I'm struggling with understanding why such a big drop.
So if we can hold that question and come back to it, it's a function of what county care budgeted is for their membership, and there's a later slide that speaks to that.
Okay, thank
But
you.
it's a direct per member, revenue times members gets us the revenue side of the equation, and they have projected continued decreases. It's a similar slide we show every year where we take the current, what the membership is currently and what they project will happen due to the redetermination process. So hold that thought, we'll come back to it.
Thanks.
Okay, so, the expense slide here, so you can see the 5.144 billion, so we are balanced. As the proposed budget here, again, the 5.144, and then the variance column, you see a lot of minuses, and effectively, if you add up all those minuses, that is the approximately 200 million that is coming out of the health system, to close the gap effectively. So taking cost out of the health system, again, which is part of, that was done to close the gap in fiscal 25 and will carry over to fiscal 26. But then on the health plan services line, you'll see that they are adding, on the county care health plan, 210 million of expenses being added. So all in all, the budget, the expense side rather, the total is only changing by about $2 million. And again, we have a slide. The next slide actually does a nice job of presenting that. And I want to also point out on the right-hand side, the FTEs, the 110 that are being added by fund. And again, that's those are mostly related to the positions that are being moved from ARPA. Okay. So next slide.
Yeah, and point of personal privilege. Most of my career was spent in public health, and investments in public health could help reduce some of these numbers. And I see we did propose a significant amount for public health, but I think there's still an opportunity to do more through public health in terms of primary prevention, keep people out of the hospital, keep people out of clinics.
Sure. So just to comment on the overall expenses, again, as Scott mentioned, we underwent a 10% reduction plan across the whole system. To close the gap for this year, we were staring down about a $120 million gap due to the shift that we've seen. We budgeted a certain amount of Medicaid, but we've had less Medicaid and more charity, right? And so we instituted cuts across the whole system. So these numbers are reflective of the 10% cut, plus adding back any initiatives, right, growth initiatives they have planned for next year. So I believe, public health is showing a net result of 4, but they actually went down by 15 and, and up by 20 or something like that to come up with a net 4. Everybody went down and then some was put back. So all of these numbers are net of that exercise. That's my only comment there. And then as Scott was saying, this slide I think really shows the budget at a glance, right? We're going from 5.146 last year to 5.144 next year, just basically a 2 million decrease or basically flat. You can see that all the greens are the decreases that I just spoke about, the 10% reduction plan. So, the position freeze we did, the contract labor reductions we've had, purchase service, medical supplies, leases, rentals, et cetera. All that is about a 200 million decrease. Again, we have to decrease the expense side because the revenue side is going down as well. We have to present a balanced budget. But then the reds were the additions, right? And so we are budgeting salary increases. We did bring ARPA people onto the health fund, and then the medical claims expenses going up. So all of that savings we did by the reduction plan was basically put right back by the increases we have coming for normal increases for next year. But this is a very good visual to see exactly sort of what happened or what we're doing. Questions on this one?
Yeah, where is the Bronzeville Health Center captured? Really, I'm talking about the previous slide.
That would be under ACHM.
Got it. Thank you.
Yep. All right. With that, I think we're ready to turn it over to Budget Director Joe Francois, just to quickly run us through each entity. Joe.
Good morning, everybody. Now we
Good morning.
each of the offices and the net changes to the budget, starting off with Stroger Hospital. Compared to FY25, Stroger's budget, it contains a $129 million reduction, which includes the continuation of the 10% reduction plan that we've been referencing. On the position side, there's an increase of 36 FTEs, which is primarily attributed to the ARPA positions moving from ARPA funds over to the corporate side. Additionally, in FY26, CCH will continue its plans to reduce its agency and registry expense with a particular focus on the largest users at Stroger Hospital, which are nursing, pharmacy, environmental services, telecommunications, and lab services. This budget also includes a continuation of its multi-year investments in strategic initiatives related to the service line expansions centered around OBGYN, cardiology, neurology, oncology, and the Cancer Center. Further, the budget will also continue its investment in the facilities and capital, which includes the replacement of an MRI machine, interventional radiology equipment and renovation of that room, renovation of the sterile processing department, as well as construction related to the parking garage and other facility improvements. Next slide, please. Over at Providence Hospital, the budget is set to decrease by about $20 million as compared to last year, which includes a reduction of nine positions, which is, again, part of the reduction plan. This is at the Crisis and Triage and Stabilization Center. Since that was rolled out in FY26, there's some additional expenses as well as volumes budgeted for centered around its mental health service lines. In FY26, the budget also continues its multi-year investments in the community by expanding its service lines at Providence, which include OBGYN, urology, and increased volumes, as mentioned earlier, centered around GI, as well as oral and maxillofacial and general surgeries at the hospital. Finally, the budget also includes general facility upgrades and investments since the general infrastructure at the hospital has degraded over time, so it continues to invest to upgrade the facility itself. Next slide, please. On the outpatient side, which is ACHN, the Ambulatory and Community Health Network, and the Core Center, the budget is set to decrease by about $37 million, as well as a increase of 13 FTEs, again, related to ARPA positions moving to corporate. Some of the key reductions driving outpatient's budget is the 10% reduction plan, which also includes focusing on its agency reduction, as well as demobilization of the new arrival center at Belmont Cragen. In FY25, ACHN opened its 8th dental clinic at the North Riverside Health Center, and in FY26, it includes preparing the expansion of oral health services at Belmont Cragen and Blue Island. This budget also continues its investment in the ACHN facilities, which includes repairs and general upgrades throughout the ACHN network, as well as at the core building. Next slide, please. Yeah.
Yeah, slides 17 and 18 indicate that we're providing oral health services. Are those contracted, or are we employing people to provide those services?
We employ people to provide those services. There's some small agency use as well. To basically supplement some of the gaps in hiring, however, is generally increased year over year for the hiring for oral health services.
Thank you.
All right, continuing for correctional health, which is the CIRMAC and JTDC health centers, contains a $15 million overall reduction, which is mostly at CIRMAC, which is driven primarily by its registry and overtime reductions through its planning, as well as some of the increases there are due to CIRMAC's continued expansion of utilizing telehealth services to maximize efficiency and provide better quality care. At CIRMAC, there's a reduction of 5 FTEs, again, related to the reduction plan, and an increase of JTDC, which includes 2 positions moving over from ARPA. Next slide, please. On the public health side, the Department of Public Health contains a $4 million increase with a net increase of 41 FTEs. These positions are again related to ARPA and are related to behavioral health, food as medicine, emergency preparedness, healthy communities, and lead abatement programs. Overall, the positions from ARPA more than offset the 10% reductions, which you would see again as a $4 million increase. And again, the county gave us an additional $10 million to cover some of these positions. DPH's budget also includes different initiatives to advertise its services to the public in FY26, as well as new community immunization programs that partners with our ambulatory networks. Next slide, please. And on the health administration side, it is set to decrease by about $11 million with a 35 increase of FTEs. Again, that 35 positions of why it's increasing are from the expense reduction plan, which converted select positions around the system to the Position Control Committee, which the Position Control Committee gives leaders a pool of positions available to reclass for different strategic initiatives or restoring the positions while senior management monitors the fiscal situation related to federal and state cuts. Even with these addition of positions, administration looks to reduce its expenses while also maintaining its investments in revenue cycle to maximize revenue through the management of denial reductions, increasing claim submissions, and investment in technology to improve billing and medical record systems. Finally, the FY26 budget also reflects the expansion of the Life Sciences Department, which supports our research operations, which was previously managed by Hectone. Next slide, please. And on the health plan services at County Care, the budget is increasing by $210 million as previously referenced, with a reduction of 3 positions, again, related to the reduction plans. Although the County Care membership is projected to be 401,000 by the end of FY25, the average over FY26 is 362,000 members and is offset primarily by the increase in the per member per month revenue of approximately 5.8%. And that is based on the state program changes and current rate trends. The reduction of the members to 362,000 is again attributed to the state programs and the elimination of health benefits for immigrants and adults population. Next slide, please. And on this slide, it will show the membership projections for FY26. You can see in December, so at the beginning of the fiscal year, the projection is about 377,000 members and reduces to just under 349,000 by the end of the year, which averages out to about 362,000 over the course of the year. Next slide, please. And finally, on this slide, this shows the projected membership for each of the membership's population, as well as the contribution, which is the net gain or loss for each of the plans. You can see at the top the different plans, and then going down the revenues and expenses for each. You'll notice that basically the largest contributor to revenue is part of the family health program and long-term services supports, as well as special needs children. And the one that actually loses money is the ACA adult, which is projected at about a $400,000 loss. But in net, County Care expects about a $1 million profit. In addition, there's a $103 million net contribution to CCH, and so this is members utilizing CCH's facilities, and we're able to capture that revenue by having members use our facilities.
I'm sorry, where did you say the big loss is going to come again?
It's a slight loss of $400,000, and it's centered around the ACA adult program, and it's the first column where it says ACA adults, and its projected net loss is $400,000 for the year.
And the loss is due to?
It's claims expense exceeding the capitation revenue. Okay, Joe, I think with that, we're going to wrap it up real quickly here with just, next slide, Debbie, thanks. Just to touch on our grants and ARPA. So next year, we will have $6 available with grants and ARPA. You can see there, ARPA is still $26.4 million that we're spending down, and the CCH and DPH grants are $42.8 million, which is comprised of over 99 separate grants, categorized, as you can see there: behavioral health, opioid and substance abuse, food as medicine, emergency preparedness, trauma-informed treatment, and healthy children and families, and also includes another 200 FTEs that are not in the counts. These dollars and these FTEs are not in the counts we've spoken about previously. These are grant funded. But it is almost a $30 million decrease in grants from last year, and the availability funds and sustainability of these programs, of all these programs, continues to be a focus and concern for CCH, as you know, as we move forward, given the federal and landscape. And the last 2 slides are just informational, and we can stop there. Just ARPA spending and the appendix, and reopen it for any additional questions.
Thank you. Thank you for the presentation. And before we open the room for comments and questions by the directors, I'm going to go back to Director Green.
Thank you so much, Dr. Henry. Given, I know in August specifically, we have some very key tariff implementation dates. Procurement wise, I didn't know if that is built into consideration or there's time to build that into consideration when it comes to medication and supplies. I know even this morning, there was an announcement on tariffs specifically for medications, noting that it can go up to 250%. So I don't know if there's been any pre-thought on it. I'm sure there has, but is there, an opportunity to kind of look at that?
Sure, so we did include natural, I would say, supply inflation costs into next year's budget, but nothing except for pharmacy, nothing specific to tariffs, with the exception of pharmacy. We did build in some extra for that.
And I know Shannon Andrews, our Chief of Diversity and Inclusion, who's also has oversight over procurement, has been in very close contact with Vizient, our GPO, and they have kind of a consortium that's providing that guidance of, what's on the horizon, what should we expect, what's the strategy, do we order extra now before additional tariffs go in, kind of how should we pivot to ensure that the impact's minimized?
Yeah, I think we're along the same lines with that. Yep.
Thank you, Director Green. Any other questions, comments, directors? Chair.
Thank you, Vice Chair. Eric, what percentage of emergency department visits that we get at Stroger or Providence are considered non-urgent or more appropriate for primary care or ambulatory care?
Yeah, I don't have an exact number. We can pull kind of the breakdown on ESI, kind of the stratification of severity when patients show up, but I will say it's not insignificant. When we looked at, a few years ago, we looked at left without being seen when the numbers were much larger, sure, and a full 25–30% were folks coming in just to get medication refills to the emergency department.
And I'm guessing that most of those people are not getting their ambulatory care from the county. They're probably attached to other providers, or they're not able to get in, and then they default to the county ER.
Yeah, I think it's a mix. I think, sometimes it could be an access issue on our part, but I think there's a not insignificant number of folks who are either in other systems or not engaged in care at all, and they just show up here when something becomes dire.
I think that's the opportunity. Mm-hmm. And I know we'll have a chance to talk more about it, but I think that's an opportunity in many ways. Because I know it came up in the mid-budget meeting last week that I attended, that, the county does a lot for uncompensated care, uninsured folks, and the question came up, I believe it was from one of the commissioners, what can we do to encourage others to help fill that gap? And I certainly think where patients are assigned to other health systems and they're not able to access that care, I'm not saying it's an access issue for county, I think it's an access issue for those organizations. Mm-hmm. And then they end up defaulting to the county, and then we have to serve them in the ER when we know that's the wrong place at the wrong time at the wrong cost of care. Yeah. So I just think it's an opportunity in many ways. Yeah. And maybe that patient wants to have access by coming to county and being served in the ambulatory clinics. Yeah. We'd happily integrate it all the way through the system. I know you're going to hear a lot. You're going to hear this from me a lot, but I just think it's an opportunity. Absolutely.
I concur. I raised that, Chair, because I question if we don't need state action. In fact, I think we do. And I think charity care maybe needs to be redefined. But that's what we'll ultimately need is state action. But we have to lead our legislators in Springfield to understand what it is we want them to act on, but that is our opportunity. Other questions, comments?
Claims expenses exceeding revenue, going back to the biggest engine we have for producing revenue, health plan services. Do we understand the essence of the claims? What I'm getting to is, are they preventable? If we can push them into the clinics, if we can get them to do their annual visits, and I know this is the magic bullet, I recognize that. But the question is, if we can identify the individuals, then can we now start to do something aggressive toward trying to get them in the right line with incentives or whatever? And I know we have incentives that are out there, but do we know who they are, and have we actually reached out to them?
So the health plan has a very robust care management program where everybody's engaged, especially those who are high utilizers, those who need additional support. I think on the provider side, our opportunity is where we've been heading. It's this alignment to focus on prevention, right care, right place, right time. You know, we've entered into multiple value-based care agreements. Now we just signed an ACO agreement to join an accountable care organization. So that whole focus is high quality in the right place at the right time. So we are aligning the organization. Again, we talk about things like access and all of that. Those are all kind of those operational things that we're working to improve so that we can be as efficient as possible without, you know, increasing resources. The other piece I will say that's, you know, a bit of it's a nuanced challenge in the health plan is that we're tending, the folks that we're losing as you know, the monthly redeterminations are going, tend to be those who are somewhat healthier. They would receive similar payments into capitation for us. They use less, so their claims expense is less. So, you know, one for one, we're kind of losing the folks who aren't driving expense, and we're keeping the folks who actually need a lot more healthcare. So we end up a little bit more upside down as we leave the folks who are giving us capitation and not actually spending healthcare dollars.
Which then causes us to really have to focus on the engagement for those individuals who are not there until catastrophe happens.
Exactly, yeah.
It looks like Director Sorrell has a question remotely.
Thank you. In regarding to some of that lowering cost in the emergency room, some hospitals have added like a walk-in type clinic that kind of abuts the emergency department so that triage may be able to reroute those clients to a walk-in for, say, those emergency refills, needing to connect to care or linkages to care through primary care. Would that be a more effective method to potentially redirect those patients from emergency department costs, but also to be able to recoup a primary care visit from a walk-in type clinic situation?
So it is something we've been exploring at a high level with Craig around how we leverage our virtual capabilities and offering that as almost a self-redirection as people come into the ED for things like medication refills, to be able to instead then engage with the virtual urgent care where they could kind of start doing some of those more primary care visits instead of going through triage and going into the ED. If they self-select, it doesn't become an EMTALA issue, but if they show up and say, I want to be seen in the ED, we absolutely have to see them. So that's, you know, but they can choose when they come in if that's a viable option for them. And to answer the question, thank you, Dr. Smith. She got me the breakdown on the ED visits, appreciate it. Level 3 is 56%, level 4, 15%, and level 5 is 2%. And I think on ESI, it's inverted, level 5 is the least severe, yeah. So 17% are essentially, you know, lower severity visits.
Director Harrington.
What does that sorry, Joe. What's that translate into dollars, do you think?
Oof, don't know.
Well, if we take the rough shot of $2,000 at a minimum, what it costs when they walk in the door, that starts to give us a thought.
Yeah.
Yeah.
So I will say, you know, back from my ACO days, an ED visit, we rough estimate about $500. And if that's for a primary care visit, I mean, that's, you know, it's your way under on that, so, yeah.
Director Harrington.
Yeah, this is just an observation I've made before. One of the things that we see, and County Care did talk about this in one of their presentations and present data that shows that there's a significant drop-off on people actually accessing care after the age of 18, 19, and 20, because there's no requirement that they see a doctor, they go, and they feel healthy. So between 18 to possibly 40, 45, or 50, people are generally pretty healthy. It's one of the things that they had not seen a doctor for, have developed into cancer, put them on the verge of having a stroke. So the sweet spot really is those people that are not utilizing the services they have because they believe they're healthy, and they're waiting for some type of symptom to drive them somewhere to get care. And if we could focus on getting them more engaged in their health, practicing better behaviors like being physically active and eating a healthy diet, we can possibly or potentially reduce some of those costs on the back end. But that's the hardest group to get in because they feel healthy. Yeah. And so they're not going to the doctor.
What would be good to know based off of that statement, when we look at the ER numbers, what are the ages? where do they fall? What are the costs associated with the different groups? If we can actually slice the data that way. Because everyone agrees with your statement, but those are the people that we want to be on the health plan because of what you stated earlier, that we don't spend a lot of money on them. If we, at least we can get them in for that annual, that'd be great. But who's really causing us the cost right now? And there's no argument again about your statement. That's absolutely based on all facts. That's true. But if we could get those numbers to see what the age ranges are and then try to address the different age ranges, because the person who is, say, 50 years old to 55 or 60 is not the same as the person that's 70, 80. And the 70, 80 person, I'm just looking at my parents. The number of times when I was in here, that's because I was in another state with my father standing in the ER, literally standing in the ER multiple times. And I'm thinking to myself, what in the heck are we doing here? And the doctors are saying, what in the heck are we doing here? And my dad's up there saying, well, I got problems. What are your problems? But if someone, we haven't been in the ER because I talk to him almost every day now. So I'm basically engaging my dad to make sure he's okay, engaging my mom. And if we can set up a system that can give that type of engagement to give direction, we might see numbers go down. We'll see the health plan pick up, and we'll see better care. Getting back to what you're saying, but that becomes a question of understanding what are the real ages that are creating that problem.
Yeah. So two things. I think Director Harrington, to your point, I think what Chair Garza keeps repeating, right, is that we are very uniquely suited in engaging those younger folks in the community with our public health team, right, so that there is that kind of cross-pollination, the ability to really engage at the community level for folks who aren't going to engage in healthcare, right, to ensure education is key. County Care does the same thing. They have a lot of educational pushes for the members, but of course that's only going to be for the members, right? So how do we get out to communities to do that education? So I think that kind of synergy is going to be key. And the other piece that I'm excited about, to your point, Director Robinson, is as we're engaging in more and more value-based care contracts, we're getting claims feeds. So it's not just what we're experiencing in the ED for our attributed patients. It's, are they going across the street to either of our, neighboring facilities? Are they going, somewhere else for care? And it will help us identify those gaps a lot more robustly because we'll see where they're utilizing care. So, they could come here once, but they might be across the street at Rush twice and then across the street at UIC 4 or 5 times, right? So it's actually 9 visits, not just one, that we're seeing with us, right? So we'll be able to do a much deeper dive into that data once we start getting those claims feeds.
Other questions, comments? Seeing none, hearing none, I will now recess this meeting to the call of the chair on Monday, August 11th at 6 p.m. Thank you. So to your point.
Mm.